Cardiovascular Disease by Dr. Muna, Red Wine Studies by Dr. Alaa, and I'll be presenting overview of statistical tests. And finally, Dr. Malaz will be talking about silent memory. So, Dr. Muna, if you're ready, you can begin your presentation.
Hello, Dr. Mohammed. Hello, everyone. Yes, I'm ready. If you can give me the permission to share a screen, if it's okay. Thank you so much. Okay, can you see my screen now?
No, we cannot see.
No, not yet.
Okay, just 1 second. I apologize, just 1 second. How about now? Can you see it?
No.
Okay. I have issues with oh, I don't think I can share my screen. I don't know, it's the setting or something.
Can you share the file with maybe Dr. Mohammed, and he can share the screen? Thank you.
Yeah, so the file is already in the application. If it's okay, Dr. Mohammed, if you can open it from your side.
Okay, just let me download it.
Sure, thank you so much. At that time, I will try my best so I can do it from my side too. Apologies, guys, for the delay. We deeply apologize.
But are you able to use a presentation, the file?
Dr. Nader, can you assist me if you can? So I think it's the setting. It's the first time I actually share screen. So I have many options on the side. If Dr. Mohammed, can you confirm if you are able to download it? If not, I can.
Can't download it. It's just that I formatted my laptop, so I don't have Microsoft. I don't have Microsoft PowerPoint to share to open it.
Okay.
Yeah, so
I'll try from my side again. We're deeply sorry for this delay, everyone, taking from your time.
Okay, why don't we go to the second topic,
Yes.
and then we can come back to
Yes, we can.
this.
Thank you so much. Thank you for understanding.
You're welcome. If Dr. Alaa is ready, maybe we can start with you, Dr. Alaa. In the meantime, we can fix a technical issue. Thank you.
Yes, hello, can you hear me?
Yes.
Okay. So hi, good evening, everyone. My name is Dr. Alaa Salah, and I will be presenting the red wine topic. It's like an update, studies update about the red wine. So now I will just share my screen. Give me 1 second. Can you see my screen?
No.
No, not yet.
It's coming.
let me see if I can share mine.
Okay, go ahead.
Can you see my screen?
Yes.
Yes.
Okay, then I think we can start with topic 1. If it's okay. Let me
Yes.
just make it. Just
Thank
let
you
me
so much.
start.
Okay, hello everyone. My name is Dr. Mohammed. Again, we deeply apologize for the inconvenience. I'm going to present cardiovascular disease part 2 today. And next, Dr. Mohammed. Okay, the objectives of today's session is to be able to describe how the cardiovascular system changes with normal aging, the signs and symptoms of the most important cardiovascular diseases in older patients, the appropriate diagnostic tests to identify the presence and severity of cardiovascular diseases, and the standards of treating cardiovascular diseases. Okay, today we're going to cover part 2, which is valvular diseases, cardiac arrhythmias, peripheral arterial disease. Part one was covered in previous sessions. Next, Dr. Mohammed, thank you. Okay, types of valvular diseases are aortic stenosis, aortic regurgitation, mitral stenosis, and mitral regurgitation. We're going to talk about each and every one of them later. Right now, the diagnosis of valvular diseases, generally we do an echogram. It's the procedure of choice. Echocardiography with Doppler can non-invasively assess the cause and severity of most acute or chronic valvular diseases or abnormalities. Also, it provides important information about left ventricular size, left ventricular function, and left atrial size, pulmonary artery pressure, and the presence and severity of other valvular lesions. Okay. First, we're going to discuss aortic stenosis. The symptoms of aortic stenosis are angina, dyspnea on exertion, heart failure, lightheadedness with pre-syncope or syncope. Physical findings would be mid to late systolic ejection murmur that radiates to the carotids. S4 gallop, left ventricular heave. On EKG, we will find left ventricular hypertrophy signs. Treatment of aortic stenosis. There are three options to treat aortic stenosis, actually two, because medical in aortic stenosis is not effective at all. So we usually go through percutaneous or surgical procedures. The percutaneous procedures are transcatheter aortic valve replacement, which is called TAVR, and selected patients at intermediate to high surgical risk. Surgical, which is surgical aortic valve replacement, indicated for severe aortic stenosis with symptoms. Bioprosthetic valves are preferred in older patients. Next, doctor. Thank you. Aortic regurgitation. Symptoms of aortic regurgitation can be acute or chronic, or can be asymptomatic or minimally symptomatic in mild to moderate aortic regurgitation. Dyspnea on exertion, heart failure, angina, and severe aortic regurgitation. Findings of aortic regurgitation in the physical exam will be increased pulse pressure, which is the difference between the systolic and diastolic blood pressure, bounding to collapsing pulses, diastolic decrescendo murmur, systolic ejection murmur. In EKG finding, we will find signs of left ventricular hypertrophy in severe chronic aortic regurgitation. Tachycardia is always found in acute aortic regurgitation. Chest X-ray, usually there is a cardiomegaly in severe chronic aortic regurgitation. And if there is any acute aortic regurgitation, the findings are pulmonary congestions. Treatment of aortic regurgitation. Medical in less severe cases, mainly to control hypertension, preferably with a dihydropyridine calcium channel blocker, ACE inhibitors, or angiotensin receptor blockers, beta blockers in patients with symptoms of left ventricular systolic dysfunction. Surgical treatment of aortic regurgitation are it's aortic valve replacement indicated for acute severe aortic regurgitation, symptomatic severe chronic aortic regurgitation. We also go for the surgical. Asymptomatic severe chronic aortic regurgitation with left ventricular ejection fraction of less than 50 or left ventricular end systolic dimension of more than or equal to 5 centimeters. Mitral stenosis. Symptoms of mitral stenosis are gradually worsening shortness of breath, early orthopnea, and leg pain. Early signs are gradually worsening dyspnea on exertion, orthopnea and leg edema are late, progressive decline in exercise capacity. Findings of mitral stenosis are early diastolic opening snap, low-pitched rumbling diastolic murmur at the apex, pulmonary hypertension, and right heart failure. Treatment of mitral stenosis. Medically, we treat patients with mitral stenosis with diuretics for volume overload and beta blockers for decreased exercise tolerance associated with tachycardia. Percutaneous balloon valvoplasty, safe and effective, but most older adults are not good candidates due to extensive calcification and commissural fusion or concomitant mitral regurgitation. Surgical treatment of mitral stenosis, mitral valve replacement is effective, but with 5% to 15% operative mortality rate in older patients. Mitral regurgitation. Symptoms can be acute or chronic. Marked shortness of breath, orthopnea in acute, severe mitral regurgitation, progressive dyspnea on exertion, and chronic mitral regurgitation. Findings, physical exam, we usually find pulmonary rales, tachycardia, narrow pulse pressure, S3, and short, harsh systolic murmur in acute mitral regurgitation. Hollow systolic murmur radiating to the axilla with S3 sound, pulmonary hypertension, right heart failure, and chronic severe mitral regurgitation. Okay, treatment of mitral regurgitation, medical treatment as for heart failure with systolic dysfunction in patients with symptomatic chronic mitral regurgitation and left ventricular ejection fraction of less than 60% who are not candidates for any intervention. Percutaneous treatment, transcatheter mitral valve repair in selected patients. Surgical treatment, mitral valve repair, preferred over the mitral valve replacement. Bioprosthetic valves preferred over mechanical in older patients. All effective with 5 to 15% operative mortality in older patients. Operative mortality is lower for the repair than the replacement. So the preferable one is the repair over the replacement. Okay, surgical intervention is indicated in those cases. Urgently for acute severe mitral regurgitation with heart failure, symptomatic patients with severe chronic mitral regurgitation and ejection fraction of more than 30%, asymptomatic patients with severe chronic mitral regurgitation and ejection fraction of 30 to 60, and or left ventricular end systolic dimension of more than or equal to 4 centimeters. When mitral valve repair is deemed likely to be successful in asymptomatic patients with severe chronic mitral regurgitation and left ventricular ejection fraction of more than 60%. Also, we consider surgical intervention in patients with severe chronic mitral regurgitation and pulmonary artery systolic pressure more than 50 millimeter mercury, or new onset atrial fibrillation with high likelihood of successful mitral valve repair. Okay, TAVR or transthoracic aortic valve replacement. TAVR with a bioprosthesis is associated with improved outcomes relative to medical therapy in older adults who are not candidates for surgical aortic valve replacement, TAVR. Shorter hospital stay, length of stay, and faster functional recovery with TAVR. Vascular complications and stroke are more common after TAVR, but major bleeding and atrial fibrillation are less common. In patients who are high risk for SAVR or TAVR has demonstrated similar or better outcomes up to at least 3 to 5 years, including risk of stroke, vascular complications, and all-cause mortality. Okay, infective endocarditis. Native valve endocarditis is most commonly caused by strep viridans or Staph aureus. Enterococcal species and gram-negative bacilli are also common causes in older adults. Endocarditis is often difficult to diagnose in older adults. because fever and leukocytosis are less common. Transthoracic echo sensitivity is reduced due to increased calcific disease and prostatic valves. Transesophageal echo improves diagnostic yield for infective endocarditis. Okay, treatment of infective endocarditis, IV antibiotic therapy for 2 to 6 weeks. Surgical therapy should be considered in the presence of severe valvular dysfunction, evidence of persistent infection despite appropriate antibiotic therapy, recurrent emboli, marked heart failure, myocardial abscess formation, high degree AV block, vegetations more than 1 centimeter in diameter on the left side of the left-sided valves, or fungal endocarditis. We consider surgical therapy. Recommendations for preventing endocarditis after dental procedure focus on providing prophylaxis only in the highest risk patients. Those with a prosthetic valve, prior history of endocarditis, certain congenital heart diseases, or cardiac transplantation with valve disease. Recent guidelines have eliminated the recommendations for prophylaxis for those undergoing GI or genitourinary procedures. Cardiac arrhythmias. Age-related changes in the cardiac conduction system, coupled with the increasing prevalence of cardiovascular disease at older age, all lead to progressive increase in the incidence and prevalence of conduction abnormalities and heart rhythm disturbances in older adults. Age-related degenerative changes in and around the SA and AV nodes increases in bradyarrhythmias with advancing age. Atrial fibrillation, the most common sustained arrhythmia seen in clinical practice. Incidence and prevalence increase exponentially with age, such that the prevalence in octogenarians is approximately 10%. Among older patients with valvular heart disease or heart failure, the prevalence is even higher, approaching 30%. Clinical features and diagnosis of AFib. Symptoms related to AFib are highly variable. Most common are palpitations, shortness of breath, or impaired exercise tolerance. In patients with ongoing AFib, the standard 12-lead EKG is diagnostic. Other studies should include echo, serum electrolytes, especially potassium and magnesium, thyroid function test. Further evaluation in selected cases may include a chest radiogram, serial cardiac biomarker proteins, a BNP level, D-dimer, lower extremity venous Doppler studies, and an evaluation for pulmonary embolism. Management of AFib. The objectives include relieving symptoms and minimizing the risk of thromboembolic events, particularly stroke. Principal strategies for relieving symptoms is to control heart rate and maintenance of normal sinus rhythm. Patients who experience significant shortness of breath, fatigue, or exercise intolerance attributable to AFib may be best managed with antiarrhythmic drug therapy aimed at maintaining sinus rhythm. Alternatives to antiarrhythmic drug therapy for maintenance of sinus rhythm. Catheter ablation of the arrhythmogenic foci, usually through pulmonary vein isolation. Surgical maze procedure. It's actually a surgery that goes around the upper chamber of the atria, and it blocks they create a scar that blocks the abnormal electrical signals through the conduction system. So they try to stop the abnormal signal at that surgical maze procedure. All older patients with paroxysmal or persistent AFib require consideration for stroke prophylaxis. Okay, so management of AFib. First, stroke risk stratification. CHADS VASC, it's CHA2, DS2, VASC. It stands for C is for congestive heart failure, H for hypertension, age for, when it says 2, it means the age is more than 75. And when it says only one A, the age is 65 to 74. The D is for diabetes. The S is for stroke or TIA. The V is for vascular diseases. The other A is for age. As we said, it's 1 point only if it's between 65 to 74. The S is sex if it's a female sex. Okay. More accurate than CHAD score. It used to be CHAD score, but now CHAD VASC is more accurate for identifying low risk of stroke. 2 points, as I mentioned, for age if it's more than 75 years. 1 point for age if it's 65 to 74 years. 1 point for cardiovascular disease and 1 point for female gender. Score of more than 2. Patient is a candidate for systemic anticoagulation. Okay, the Has-Bled score, it actually stands for hypertension more than 160 millimeter mercury. The A is for abnormal renal or hepatic function. The S is for stroke. The B is for bleeding history or any predisposition of bleeding. The L is for labile INR. The E is for elderly more than 75 years. And the D is for drugs if the patient is taking antiplatelet, NSAIDs, or drinking alcohol. The Has-Bled, it's a score that is useful, adjunctive tool to promote informed decision-making by estimating the patient annual risk of major bleeding. So it's usually in patients who are already anticoagulated, so they just assess the risk of their bleeding or the need of more anticoagulation. Okay, next. Okay, management of AFib. 2, stroke prophylaxis. Warfarin titrated to maintain an INR of 2 to 3. Aspirin 75 to 325 milligram per deciliter, plus or minus clopidogrel. Just the side information, whenever you take a smaller dose of insulin, it has, of aspirin, it has antiplatelet effect. And whenever it goes up to 325 milligram per deciliter, it has more anti-inflammatory effect. So the lesser, the better as antiplatelet. The active W trial demonstrated the superiority of warfarin to the combination of aspirin with clopidogrel in terms of both risk of ischemic stroke and major bleeding in patients with AFib. Direct oral anticoagulants, there is a table in the application, you can check it. It's the table 50.4. For AFib patients with elevated CHADS-VASC score, in whom chronic anticoagulation is contraindicated, consideration should be given to percutaneous left atrial appendage closure, which is called the Watchman procedure. It's actually a procedure that they put like a parachute-shaped implant that will be around the left atrial appendage. It expands and seals off the left atrial appendage. At that time, it prevents the clots from escaping the left atrium into the bloodstream. Next, thank you. Other supraventricular arrhythmias, atrial flutter, usually occurs in older patients with concomitant AFib, and both anticoagulation and rate control considerations are similar to that of AFib. Patients with typical atrial flutter that is either symptomatic or refractory to pharmacologic rate control should be considered for a catheter atrial flutter ablation. Atrial tachycardia or AV nodal reentrant tachycardia and multifocal atrial tachycardia treat underlying condition provide pharmacotherapy aimed at rate control or arrhythmia suppression. In selected patients with recurrent symptomatic episodes, antiarrhythmic medications or catheter ablation may be considered. Ventricular arrhythmias. Frequent ventricular premature beats, ventricular couplets, and short runs of non-sustained, less than 30-second ventricular tachycardia, they require no therapy unless highly symptomatic, in which case beta blocker is the treatment of first choice. Longer episodes of ventricular tachycardia with dizziness or syncope, refer to a cardiologist or electrophysiologist for consideration of antiarrhythmic drug therapy, catheter ablation, or implementation of a cardiac defibrillator for secondary prevention. Next, doctor.
Yes, let me reshare it.
Thank you so much.
Showing me that I'm not able to resume the sharing.
Can someone else assist in sharing screen?
I think
Which
now it's
page?
clear.
I can try to start from the page last. Which one was the page or page number?
23.
This might be different, but I'm going to share the screen. Is this the right one? Is it or before? Or?
Yes, next.
Okay.
Thank you, doctor.
A bit.
Yes, thank you.
Welcome.
Patients with mild bradycardia, resting rate 50 to 60 beats per minute, are often asymptomatic. Patients with more marked bradycardia, resting heart rate 40 to 50 beats per minute may experience fatigue, lightheadedness, especially on standing, or reduced exercise tolerance. Pre-syncope or syncope may occur in patients with profound bradycardia, heart rate of less than 40 beats per minute, or asystolic poses more than 3 seconds or equal to 3 seconds, whether due to sinus node dysfunction or heart block within AV node or infranodal conduction system problem. Diagnosis of bradyarrhythmia: exclude significant electrolyte abnormalities, measure of thyroid function to exclude hypothyroidism, and review medications. So everything that is correctable, we try and correct it. Unexplained pre-syncope or syncope, carotid sinus massage to evaluate for carotid hypersensitivity. If there is an abnormal response to carotid massage, it is an equivocal reproduction of the patient's symptoms. For example, syncope. asystole more than or equal to 3 seconds, or a decrease in systolic blood pressure more than or equal to 50 millimeter mercury in the absence of symptoms, or more than 30 millimeter mercury in association with symptoms such as dizziness and presyncope. Okay, diagnosis of bradyarrhythmia. If symptoms occur daily or almost every day, a 24 to 48 ambulatory monitor may be helpful for confirming or excluding bradyarrhythmia or bradycardia or other heart rhythm disorder as the proximate cause. In patients whose symptoms occur at least once a month but not daily, a 30-day event monitor may provide a definitive diagnosis. In patients with rare, less than monthly, but recurrent symptoms of a serious nature, such as syncope with injury, an implantable loop recorder may be considered. Correct any treatable causes, such as hypothyroidism, and eliminate potentially offending medications if possible. In patients with confirmed symptomatic bradycardia, not amenable to conservative management, permanent pacemaker implantation is warranted at that time. Okay. Peripheral arterial disease encompasses disorders of abdominal aorta, renal and mesenteric arteries, iliofemoral popliteal artery tree. Prevalence increases with age and is higher in men than in women. Risk factors include hypertension, diabetes, cigarette smoking, and to a lesser extent in older adults, family history. Diagnosis of peripheral arterial disease. At least 50% of patients with PAD are asymptomatic or attribute their symptoms to another disorder. Formal history and physical exam to screen for symptoms and signs of PAD is recommended. Recommended for patients 50 to 69 years of age with risk factors for atherosclerosis, patients more than or equal to 70 years with or without any risk factor. Men more than 60 years with a family history of AAA, abdominal aortic aneurysm, and men 65 to 75-year-old who have ever smoked should undergo abdominal ultrasound to screen for abdominal aortic aneurysm. Treatment of PAD, aspirin, as clopidogrel is recommended as a reasonable alternative to aspirin in selected patients. Combination of aspirin and clopidogrel may be considered in patients at a high risk of vascular event and acceptable low risk of bleeding. An ACE inhibitor or ARB for prevention of cerebrovascular events is reasonable in patients with symptomatic PAD. Patient with leg PAD should exercise regularly. Revascularization is indicated for patients with severe symptoms attributable to PAD that have not responded to aggressive risk factor modification or exercise or pharmacotherapy. Revascularization is also indicated for patients with critical limb ischemia, defined as rest pain, ulceration, or gangrene. In this context, revascularization has been shown not only to improve symptoms, but also to reduce the likelihood of subsequent amputation. Management of AAA. Indications for AAA repair: development of symptoms, rapid aneurysmal dilatation detected during serial assessment, more than or equal to 1 centimeter in a year, and aneurysms that are more than or equal to 5.5 centimeter in diameter. Patients with asymptomatic AAA, they have the diameter of 4 to 5.4 centimeter, should undergo repeat evaluations at interval of 6 to 12 months. Choice of open or endovascular surgical repair of AAA is based on location of the lesion and patient comorbidities and prognosis. Shared decision-making in cardiovascular disease. It entails patients expressing their preference and values and clinicians providing relevant details for the risks and benefits of treatment. There are two websites you can visit. There is the patient decision aid for ICD or left ventricular assist device implementation, and there is my clinic decision aid for potential benefits of statins. In summary, calcific aortic stenosis is the most common valvular abnormality requiring intervention in older adults. Surgical aortic valve replacement is the standard treatment for aortic stenosis in healthier older adults, while TAVR, transthoracic aortic valve replacement, is an effective alternative in older adults at a moderate to high risk of surgery due to other comorbidities or frailty or other factors. AFib increases in prevalence with age, and more than 50% of all patients with AFib are age 75 years or older. Most older patients with AFib respond to rate control medications plus antithrombotic therapy, but some require antiarrhythmic drug therapy or other interventions. The prevalence of peripheral arterial disease increases progressively with age, and peripheral arterial disease is a potent risk marker for concomitant coronary artery disease and cerebrovascular disease. Management of PAD should include appropriate treatment of hypertension, dyslipidemia, diabetes, and tobacco abuse in accordance with existing practice guidelines. Okay, so done with the presentation, I'll be presenting 3 cases. I'll read the question and
we can skip the cases for now.
No problem.
Yeah, but thank you so much for a great presentation. So I want to open the floor for any of you, if you have any experience with patients with these conditions. What's your perspective, or how, if you want to share some of your experiences? One thing I noticed, the progression or the guidelines changes and the tools are changing. So we started earlier, several years ago, when we asked about anticoagulation in patients with AFib. So we use a tool, and now we use a different tool, as mentioned in this presentation. Can anyone also share your experience if you saw patients with any of these conditions? Thank you. I'll start with you, Dr. Muna. Do you have any comments, or Dr. Mohammed maybe? Thank you.
From my side, I had 2 patients with severe aortic stenosis. Both of them, they underwent TAVR. It was recommended by their doctors, and they had really, they're still home and with the follow-ups, and yeah, that's my experience. Oh, I have another experience with a peripheral arterial disease. He was an elderly patient that he complained of claudication. Whenever he walks, he stops because of the pain and everything. And in the practice, we checked his ABI. It's actually, we do it with a QuantaFlo test, which is a lot easier in the practice. And it was really severe. I remember one of them was 0.4 and the other one was 0.6. But he started the exercise and walking regimen, and with the medication and control of underlying disease, he's doing really good. Although he's maybe 82 years old, but it was a really nice outcome. Yeah, thank you.
That's great to share. Thank you so much, and I'm glad that the patients felt well.
Yes, I have a case also.
Go ahead.
I have one of my relative. He's 50 years old. I think he was diagnosed with aortic regurg. He has also SLE, systemic lupus erythematosus, and it affects his kidney, and also he has aortic regurg, and he was planned to do open cardiac surgery to repair the aortic valve. But unfortunately, he died during the surgery because the surgeon said he was fine, his valve almost, he was severe damage, and he explained the valve, it looked like just like tissues, like napkin tissues, and he passed during the surgery, unfortunately.
I'm so sorry about that. Sorry for the loss. Yeah. Thanks for sharing the experience, though. Anyone else?
Hello.
Hello.
Can you hear me?
Dr. Aisha. Yes.
Hi, Dr. Nade. How are you? Hello, everyone. I want to share an experience. I have interacted with a patient. He was relatively young, like his end of 40s or something, and it was very interesting because I've seen one of the rarest sign of aortic regurg, the one with the head nodding. His aortic regurg was due to untreated rheumatic fever, and it was very severe that you can visually see his head nods like this. Tuck, tuck, tuck. And it was like a spot diagnosis. Immediately when the doctor I was in the round with, he just diagnosed him from that sign. Of course, he went for more investigations and ultrasound, but it was like just a spot diagnosis, and it was very rare. He has more signs like the water hammer pulse sign, and every sign in the book you can imagine he had it, and it was like, oh, interesting. I didn't follow up with that patient because we moved on, but like it was very interesting to see all the signs mentioned in a textbook in real life. Thank you.
Thank you so much, Dr. Aisha, for sharing that. Yeah, it's nice when you have these rare cases when you see the actual textbook and you see it alive. Yeah, that's very good. Thank you for sharing.
Thank you.
Okay, I think we can move on to the next topic when you're ready. Dr. Alaa, if you have trouble with the screen, can you share the file in the chat? Maybe I can.
Yes,
help.
I shared it in the app, in the fellowship app. It's file 3. It says red
Give me a
wine.
second. Give me a second. Thanks for sharing the experience. Okay, when you're ready. Thank you. Dr. Ara, I think you are muted. Can you hear me? You can start if you can hear me.
All right, yes. So hi, good evening, everyone. And my name is Dr. Alaa. And today I will be presenting the red wine and its relation to the heart health. So in this presentation, it will provide you with an overview of the red wine and what both earlier and more recent studies have shown about its effect on health. We'll also explore the current evidence regarding the provided benefits, risks, and mechanism by which the red wine components may influence the human health. So by the end of this session, we aim to have like a more clear overview, and we have like an evidence-based understanding that can help us in the clinical decision, like in the decisions in our clinical practice. So it will be more like an uncorking of the truth. So let's go through this topic. So earlier, like long time ago, there was a very huge reputation about the red wine, and there was like some terms used about this drink. They said the French paradox, and there was like an allure. For decades, the red wine was celebrated as a heart healthy. So why did this belief take hold? And why did the red wine earn its heart healthy reputation? So when the scientists studied the red wine and the component of the red wine, they came to a conclusion about it that gave them this like these terms they used about it. It's found that the red wine contains a substance called the resveratrol. This substance was the star compound, along with other antioxidants components, which was found abundantly in the red wine. So, what exactly is the resveratrol, and what is the properties that this substance have make the red wine a like a heart healthy drink? So these substances, like the resveratrol and the antioxidants, were thought to offer a protective benefits. So what are those benefits? Inside the body, the resveratrol help to reduce inflammation inside the body. It's prevent the LDL, which is the bad cholesterol, from oxidation. It also improve endothelial function and reduce platelet aggregation as well. All of these criteria or all of these functions help to reduce the cardiovascular events and incidents. So that's why it's thought to be a heart healthy drink. The resveratrol was found abundantly in the grape skins, which is the main source of the red wine. So it was found in the skins of the grape. It's found in the red wine itself, in the berries, and in the peanuts. So and multiple other plant substances. It was like very rich in this resveratrol. As well, there was a term used to be familiar or famous at that time. It says the French paradox. So the French paradox, the studies noted that there was lower heart disease rates in France despite a high fat diet. And this lead the researchers to hypothesize that the red wine was the protective factor. They came to conclusion that the red wine is the protective factor. So what is the French paradox? The French paradox term coined in the 1980 to 1990, when some observational studies noted that the French population had a high intake of saturated fat with a relatively low rates of heart diseases. So despite their diet was not very healthy, it was rich in saturated fat. Despite this fact, they have a low rate of heart diseases. So those two facts are contradicting to each other. This is why the term French paradox came up to the surface. So the researchers sooner came to a conclusion that those French people, they used to like to drink alcohol, and especially the red wine, very very like they use it so much, and it was like abundant in their culture. Like each and every table they used to drink red wine in a very large amount. So that's why they came to conclusion this substance, the consumption of the red wine, protect the French population from the heart diseases and the cardiac incidents. As well, there was like the media at that time popularized this idea heavily. As well, the industry itself, the red wine, it was like a good idea for them, so that's why they popularized it even more. All of these facts together came to the conclusion of the French paradox and the heart healthy about the red wine. It was alluring at that time. It was 1980 to 1990. After that, when the science grow up, and they have a better view, they have a closer look at the red wine itself. So they want to know what is true and what is myth. When the science examined the red wine carefully, the narratives supporting the red wine and its cardiovascular benefits, it's largely collapsed. So why this happened and why the enthusiasm about the red wine cooled, and why all of the like previous terms used like it fall apart, and all of it it just vanished by that time. So they have a closer look at the red wine. It found to have a very small amount of the substances we said about the resveratrol and the antioxidant substances. They found that the actual polyphenol content in the red wine is as follow. In 1 glass of red wine, it's found to have like 0.3 to 2 milligram of resveratrol. It contains only 2 to 10 milligram of quercetin. It also contains like 10 to 50 milligram of catechins. This is the actual content of 1 glass of wine. It was very low doses of the substances. While they studied the therapeutic doses in a human trial, like they studied the human body, and came to a conclusion that if a substance need to take its effect to be protective from cardiovascular diseases or any other diseases in the body, they need a resveratrol of at least 100 to 500 milligram per day, while the quercetin, like at least 500 to 1000 milligram per day, it will be of a protective effect. Regarding the catechins, like 200 to 400 milligram per day is the needed amount from these substances. So if we took like a closer look for these values, the top and the bottom, there was a huge gap between the values. And to match these clinical doses, for one person to have a protective effect of a red wine, at least he need to consume 50 to 300 glasses of red wine per day. So this is like impractical. The biology simply isn't plausible for any real world consumption. No one can take 50 to 300 glasses of wine per day. It will have very severe side effects of alcohol, for the toxicity, for the ethanol. It will be simply unapplicable. So to gain the benefit, you will have a very there was no comparison between the side effects and the benefits from the red wine. So the bottom line that these compounds are really interesting. The resveratrol, the polyphenol, and all of the antioxidants, they are interesting substances. However, the red wine is not an effective delivery system of these substances. So the weakness of the polyphenol argument. Now, the argument they used to say in the past, now it is weak, it's fall apart. The cardiovascular benefits largely hangs on its polyphenol content, as we said. However, this remain a weak foundation for several reasons. As we just said, the doses are very low. It is subtherapeutic. It is not beneficial in these low doses in red wine. Also, there was a lack of demonstrated benefit. There is no comprehensive review that has definitely demonstrated cardiovascular benefits from alcohol-derived polyphenols at real-world intake levels. What that mean? Like even the substance of the polyphenol, which is inside the red wine, it's not proven to be beneficial. This is not a beneficial source of these substances. Although it is abundant in the red wine, it is not beneficial. There is no single study that came to conclusion these substances are beneficial when they are inside the red wine. Also, we all know that alcohols has many detrimental effects. It has huge side effects in the human health, in the cardiovascular system, in the central nervous system, and in many different aspects in the human health. And it was like there's solid background regarding the side effects of the alcohol. So we cannot just bypass the side effects, which are very known, to talk about benefits which are not proven yet. Any theoretical benefits from polyphenol is consistently outweighed by the well-documented detrimental effects of ethanol on the cardiovascular system and overall health. So now the science is at the point that there was very weak benefits from the red wine. So what about the French paradox? What is the real reason that those people at the past were had like very low rates of cardiovascular diseases despite their diet? So if it is not the red wine, what was the reason? They found that the lifestyle, not the wine, was the reason for those people to have low cardiovascular rates, along with other confounding factors. So let's see what was those reasons. The answer lies in flawed methodology and confounded data that obscure the true drivers of health. So earlier, at that time, there was the reporting system was weak and the data was not complete. So by that time, they were not documenting the mortality rate in a good way. It was underestimated, and this led to skewing of the apparent benefits toward the consumption. This is why they took this they took this weakness toward the consumption of the red wine as the reason of the low mortality. However, it was just like underreporting of the real rates of the cardiovascular death at that time. Along with the Mediterranean diet, so the Mediterranean diet, which was followed at that time, it was rich in organic, healthy food instead of the processed food and the fast food. They found that the Mediterranean diet followed at that time, it was rich in whole food, in healthy food and nutrients, which was like not in any ways like the currently used unhealthy food, fast food, and processed food. This was a major confounding factor. The researcher at that time failed to isolate this as a reason. They did not consider the diet which was followed at that time uh, as a reason for the healthy population or the low rates of cardiovascular diseases at the old people. So now they came to this conclusion, especially after the uh, like transformation of diet that is happening nowadays. So, as we just said, they failed to isolate this as a confounding factor. It's also noted that those people, the old people, tend to have a higher level of physical activities along with strong social patterns. All of these factors together made a solid protective benefits from cardiovascular diseases. It helped to grow the human health, and all of these factors are unrelated to wine. So if we take like closer look of all of these factors, this has nothing to do with wine. The evidence is clear. It was the lifestyle and not the wine. So by the modern evidence now is dispelling the myth. Now we lost all the myth. It's all just all facts. When rigorous modern studies control for critical confounding factors, socioeconomic status, and diet quality, the smoking and the physical activities and the sequitur bias. They now studying the real confounding factors. They let go for the red wine and they're looking for the socioeconomic status of the population. They're looking closely to their diet, the quality, and the type of diet they are following. They're looking for the bad habits like smoking. They're looking for the good habits like physical activities. All of these factors are now studied thoroughly to dispel any myth. And they came to conclusion about the apparent protective effect of red wine. It was really vanished entirely. The WHO in 2023, they unequivocally stated there is no safe level of alcohol consumption for health. It was like a stark reversal from earlier guidance. The old thoughts about the protective effect of the red wine now is just reversed when the WHO stated clearly that there is no safe level of alcohol consumption for human health. The GBD, which is the Global Burden of Disease Research, uh, like for three decades, they consistently demonstrated that alcohol increased adverse health outcomes across all populations. They stated it very clearly. It has like an adverse effects for human health. It is like not healthy across all populations and all ages as well. While the World Heart Federation, the WHF, identifies alcohol as a global burden, not only for heart disease, but across multiple disease categories. Now we're talking about cancer risk, we're talking about cardiovascular risk, infectious diseases, injuries. All of these are like adverse effects of alcohol. The World Heart Federation, they are talking about, not just the cardiovascular risk. And if we take a closer look at the genetic studies based on the Mendelian randomization, they also stated that there was no evidence of any causal protective effect of alcohol on cardiovascular health. This is even in more primitive basis. So all of these foundations came to conclusion that the red wine has nothing to do with the human health, and they like it's not a beneficial compound. There is no beneficial compound in the red wine to outweigh the proven harms of the alcohol it contains. Right. So let's now discuss the true sources of heart healthy compounds. Although the science was deficient back then, but they gave us like a preview about the substances in the red wine, which was really helpful in the human health. Now let's look for other sources for these compounds in more healthy compounds, like in more beneficial compounds. Importantly, the same benefits once attributed to red wine's components can be found in a variety of healthy alternatives without the toxicity of alcohol. Of course, we have the grape. The grape is the main source of the red wine itself. So we can take the grape as a fruit, the grape juice, and berries. All of these plants are like rich in anthocyanins and other beneficial compounds. All of these are like protective from cardiovascular diseases. They are abundant in the antioxidants and the resveratrols. Also, the dark chocolate, which is a source of flavonols, known for their antioxidant properties as well. The green tea is abundant in catechins, particularly epigallocatechins, gallate, e.g., CG. This is very helpful in antioxidation. It's an antioxidant substance found abundantly in the green tea. All of these are polyphenol-rich diets and are associated with reduced cardiovascular diseases and is proven to to improve the vascular function and to reduce the vascular incident inside the human body. Along with the exercise, which is a proven, documented, like very effective way to boost the cardiovascular health with multiple mechanisms, especially the aerobic exercise. The aerobic exercise, like brisk walking, cycling, swimming, or jogging, or even more intense exercise, are very proven to improve the cardiovascular health. And what matters really in exercise is the consistency. It's more important than the intensity. So you can just go with simple exercise like walking. It will be very, very helpful in improving your overall health and your cardiovascular health instead of wine, of course. So now, everything was good, but there was like an observational studies now are showing and are flowing on the science. The studies now are showing and reporting lower cardiovascular risks with light wine intake. Now they're talking about the quantity. The science is showing that there is lower cardiovascular risk with light wine intake. White intake. They're not talking about moderate. They're not talking about larger intake of the wine. It's just light intake. However, even their authors for these studies, they are caution against using this as a justification for drinking. They are caution about this. However, some parties may use these studies as like to popularize the idea again. We just need to remind ourselves that these are observational associations, and the observational association do not equal causation. uh, we need to remind ourselves that the evidence linking even moderate alcohol to increase cancer risk, cardiac arrhythmias, and other health harms for outweigh any potential observational benefits. So, as we said, these studies are not definitive. So, if you have your patient who is not drinking already, he was not drinking alcohol, there is no any proven study to recommend alcohol because there is no proven benefits, and instead there are real risk which is documented. If you have a patient who is already drinking alcohol, you can, as a doctor, you can just suggest to keep it minimum, the minimum as possible. It's because this is not a treatment, and the less of alcohol goes inside your body, the better your health will be. So you can just recommend to your patient to minimize alcohol as much as possible, and that's it. So as a doctors, we need to prescribe what works, question what doesn't, and guide our patients with evidence and not myth. This is the take-home message, guys. If like anyone have any question or any comment, you can go ahead. And thank you so much for listening.
Thank you so much, Dr. Ala, for great presentation. And any comments? So basically, this showed that some studies in the past do not show the evidence, and we need to review whatever in the literature and see if we need to depend on them or review them and change them as we go along. And I think it gives us a good idea if there is no systematic review in this area. Maybe we can create a research project in this area, see if we can write it as a maybe abstract or even a paper. Thank you again, Dr. Ala. We can move on to the next presentation.
You're welcome, Dr. Nader. Thanks for listening.
Hello everyone. I'll be presenting topic 3. Let me share my screen. Choose one.
Dr. Mohammed, maybe there is a technical
Is it
issues.
showing?
No. It shows that you started screen sharing, but for some reason it's not showing. Do you want to try to log out or log in? Or maybe you can share the file, is it PowerPoint? You can put it in the app, and maybe one of the fellows can share it
Because
or
it's,
present it.
yeah, it's PDF, but with Mozilla Firefox, you can make it full screen and show it in a slide format.
So do you want to upload or maybe share it in the chat? And Alaa, can you present it if you don't mind?
Let me try. Try it, yeah.
Yes, I will try.
Is it showing now or no, the same issue?
It's just saying that you started the screen sharing. So it may be just the browser or the app itself, Zoom app
think
on your
it's
computer.
because it was working just now earlier.
You don't mind if you share it with the Alaa or the chat or upload it to the app so she
Let me
can
see.
just open it.
Yes.
Just let me check if it's already there, because I've already set it for uploading. No, it's not this. I uploaded as file number 5.
Okay, let me check it.
Alaa, you can click on the 3 lines on the left upper corner of the black area. To the left, yeah, thanks. When you are ready, Dr. Mohammed, you can go ahead.
Yeah, sorry for the delay. My name is Dr. Mohamed Makkawi. I will be presenting on how to choose the correct statistical test. Well, as doctors, we try to do a lot of research, as they say, publish or perish. So as important as we do the study, we should also know how to choose the correct statistical test when we're doing our studies. Can I have the next slide, please? Okay, so before we start, let's get oriented on some important terminologies. A very important, very common term is something that we call the normal distribution. So because it is important because some statistical tests work on normal distribution, and if your population is not in the normal distribution, we use a different type of test. So normal distribution basically means when you align all of your population, the data, they are distributed in a symmetrical way with no skew, mainly with the majority of the cases being in the center, and then they taper out towards the end without any skew, without one side having more compared to the other. Then we may say we have a test is a parametric test. It means that this test is used in a population with a normal distribution. Non-parametric means it's not normal, a non-normal distribution. Next slide. Then there are different types of data. We have the numeric and categorical data. So when we numeric data means usually we give we report the data as numbers. For example, we collect blood pressure. We report the blood pressure as 130/80, or temperature or income. Then we have categorical. So rather than just reporting it as numbers, we report them as category. For example, in the blood pressure, you can just report it as high, normal, low, high, normal, very high. So it's called categorical variables. Next slide. Okay. Then we have correlation and prediction. So correlation means that two things happen at the same time, and how closely they occur together. Then prediction, another word for it is regression. So with prediction or regression, we try to estimate from already given data, and we try to extrapolate to find out what the data could be if we continue to gather more of it, or it could be another variable. Next slide, please. Then we have correlation with causation. This is a very common issue in many researches. Just now, Dr. Alaa has been talking about how red wine has been shown to be protective to cardiovascular disease, but actually it wasn't the red wines, actually the different lifestyle changes such as the diet and physical activity. Similarly, so it is important to note that in any type of research, correlation does not imply causation. Like just because two things happen at the same time and together does not mean that one causes the other to happen. I can have the next slide. This is a very famous example that any teacher in statistics likes to use to explain explain correlation and causation. For example, you have this graph here that shows the rate of shark attacks and ice cream sales in a local beach. We notice that they all go together. As the ice cream sales increase, the number of shark attacks increase. But is the increase in shark attacks due to the ice cream scales? No. It is usually due to a third factor, which is a more warmer weather, which is seen in the summertime. That is why the shark attacks tends to increase. So it is just important. What I just want to hammer down this point is that correlation does not mean causation. Next slide, please. Okay. Then we have two types of errors known as type 1 and type 2 error. So type 1 error, which is just simply known as false positive. Here, when we have the null hypothesis usually when we say that there is no difference between these two cases. So if the null hypothesis is true, but we reject it wrongly, saying that there is an effect, even though there isn't an effect, this is known as a type 1 error. So essentially, basically, it's a false positive. So we say that there is an effect, but in fact, there is no effect. Type 2 error is where the null hypothesis is false, but we did not reject it. This will cause that we detect that there is an effect, but we do not detect it. So we miss a true effect. This is known as false negative. Next slide, please. So this diagram will clearly show it. If we reject the null hypothesis, but the null hypothesis is true, this is known as a type 1 error or a false positive. While if we fail to reject the null hypothesis, while the null hypothesis is false, this is known as type 2 error or false negative. Next slide. Okay. So basically, we can just, this diagram can explain everything. As researchers, we are just considered as the chef. We're trying to prepare our dish, which is the soup. The soup is our sample, and the pot is our sampling frame. So in order to test to see whether the soup that we are preparing, is it adequate, is it correct, is it done well, we'll have to taste it, right? In order to taste it, that is our sampling technique, which is shown here by the soup ladle. So if we don't use appropriate sampling techniques, we will not be able to taste the soup. For example, if we use, instead of the ladle, if we use a fork, we will not be able to taste the soup. Similarly, in order to get the correct data, to get the correct information that we need, we have to choose the appropriate sampling techniques. Next slide, please. So let's start by talking about some sampling techniques and sampling test, and then we will go through a simple, very simple diagram on how to find the correct sampling techniques depending on your study. So let's say that you're describing a sample. You have a student, you have a class, and you wish to describe a certain trait. For example, let's talk about their grades. Here we will use the descriptive statistics, like we have the mean, median, mode, standard deviation, and range. So if you want to describe the class, we can just find the mean of their grades, the median, mode, standard deviation, and range of their grades. And this will help us to understand how good or how well did this particular class did. And here we're just talking about the sample that we have here. We're not comparing with another class, for example. We're just talking about our class. Next slide, please. Okay. Comparing two means here we are comparing two classes. We have class A and class B. So how do we know that one class is better than the other? So in order to compare two means, what test to use depends on sample size, if it's a smaller, less than 30 or greater, or its distribution. We have talked about earlier if it's a normal distribution or not non-normal distribution. And then some tests, they work if you're comparing two classes, and others if you're comparing 3 or more classes. Next slide, please. Can I have the next slide? Yeah. So we have a student t-test. Student t-test is used if you are comparing two, and they have to be normal distribution, and the sample size have to be small. If you're comparing just the sample size normally should be less than 30 in order to use student t-test. So there's just a small example that we're just comparing the mean of heights of two classes, and each class is 25 students. So here in this case, we can use the student t-test. Then we have the Welch test. The Welch test is used if you're comparing two populations, but their sample size varies considerably. Like in the example of the students I've given you, both classes have 25 each. But sometimes you may have to compare 25 and 50. So in that case, we cannot use the student t-test. We have to use the Welch test because they have different sample sizes. And you use it in normal distribution, if the population is normal distribution. Okay, next slide. Then we have the Mann-Whitley test. Mann-Whitley test is used if you're comparing two populations, but they should not be in a normal distribution, non-normal. So it's called a non-parametric test. If we say non-parametric test, we mean that test that is used if the population is not in a normal distribution. So if you want to compare if the advertisement of brand X resulted in a higher purchase likelihood compared to brand Y, here the population would be skewed because there is an obvious preference to one brand over the other. So here we have to use a non-parametric test, which is Mann-Whitney. And here, because we're comparing just two, we're going to use Mann-Whitney. Yeah, next slide. Then we have the ANOVA test. ANOVA test is used if you're comparing 3 or more. But most commonly it's used when you're comparing 3. It can be used for 3 or more scenarios. For example, if you want to compare heights of 5 classes, we can use ANOVA test. This diagram is just showing, to just clarify this, that we're comparing the means of 3 classes, and which test do we use? We use the ANOVA test. Next slide, please. Then Kruskal-Wallis test is similar to, it's just actually a subtype of ANOVA test, but this one is a non-parametric, which is again used if you're having a non-normal distribution. Okay. Then this is used to see, then we have the chi-square test, which is very commonly used in statistics. So it's used to compare observed results with expected results. So you already know that, for example, in this example, we want to know whether gender, if either male or female, do they influence movie snack preference or not? Then we compare it with what we observe when we do the study versus the expected. For example, we expect that women are more likely to order snacks compared to men. But when we do the study, we find that men are more likely to order snacks. So to compare this, we use the chi-square test. Next slide, please. Then we have the Fisher's exact test. It is similar to chi-square. The main difference is if we are predicting that one of these slots that we have just shown in the example is less than 5, in that case, we have to use the Fisher's exact test. The chi-square test will not work if one of these variables are less than 5. Next slide. Then now we're going to talk about a correlation. So we have 2 types of correlation. We have the Pearson correlation. They focus on if you want to find a linear relationship between 2 continuous variables. And it should be normal distribution. So here we'll use the Pearson correlation. If you want to find if there is any correlation between 2 hours spent in studying and exam performance in a normal distribution population, we will use the Pearson correlation. Next slide. Then we have the Spearman. Spearman correlation is a non-parametric measure of the strength and direction of associations. And both of these correlations will compare between just two variables. For example, here we are analyzing if there is rank orders such as athlete ranks between those who got gold, silver, and bronze to their performance scores. Next slide. So how to interpret usually the correlations given by using the letter R, and it ranges from -1 to 1. With 0 means that there is no correlation between the structure between them, and if it's a positive number between 0 to 0.1 to 1, it means that there is a positive correlation. Means if one of them increases, the other will also increase at the same time. And negative and if it is below 0, means up to -1, it means that there is a negative correlation. If one increases, the other will decrease. And next slide, please. Then we have regression. Regression here, we are trying to find a linear relationship between 2 continuous variables. Usually one would be independent, which is the outcome, and another is independent, which is the predictor. For example, if you want to predict weight based on height, we use a simple linear regression. Here we're just comparing one dependent and one independent. That's why it's called simple linear regression. Next slide. Then we have the multiple linear regression. Here we compare a single continuous dependent variable and two or more independent variables. And this is used more commonly if you want to forecast, because we have usually multiple variables that can affect regression. So if you want to account for multiple factors, we use the multiple linear regression. Next slide. This diagram shows an example. Simple linear regression, you can see it has only one line, while multiple linear regression will have multiple lines because you're accounting for multiple factors at the same time. Next slide. Then finally, we have logistic regression. Here we use logistic regression if we have two outcomes, have a binary outcome, either yes or no, either zero or either present or not present. So if we have only two outcomes, we use a logistic regression. Here it differs from the linear regression because they're in a straight line. Logistic regression usually have an S-shaped curve. So for example, if you want to determine graduate school admissions based on one or more factors, here the GPA and GRE, and to determine whether the student graduates or not, we use a logistic regression. Next slide. So we have been talking about the various types of sampling techniques and what statistical tests. So let's talk about, we are having a study, what statistical test should we use? So first we have to know what is our outcome variable. Either it's continuous or binary or categorical. If it's binary, we go with logistic regression. If it's categorical, we either go with chi-square or Fisher exact, depending on if one of the if all the figures are greater than 5, we go with chi-square. If any one of them is less than 5, we go with Fisher's exact. If it's a continuous variable, we have another extra flow. So we compare. So we should know how many groups are we comparing. If we are just describing one particular group, like one class, we use descriptive statistics. If we are comparing two groups or three or more groups, we have different statistical methods. Okay, next slide. Okay. Yeah, if we are comparing two groups, and if they are same subjects but it's done twice, we do a pair t-test. If we're comparing two groups with a normal distribution, it's preferable to use a Welch t-test just to account for any differences between their sample sizes. And if they are not in a normal distribution and two groups, we use the Mann-Whitley test. Next slide. If we have three or more groups, then we use ANOVA if it's normal data, and if it's not normal distribution, we use the Pruscal-Wallis test. Next slide. Then if you just want to find associations, and if it's a normal distribution, linear, we use the Pearson correlation. And if it is in a non-normal distribution or ordinal, where our figures are ranked, we use the Spearman correlation. Next slide. Okay, so we'll just conclude by some common mistakes done by researchers. Just what I mentioned, people tend to use Pearson on skewed data. So skewed data means it's not in normal distribution. So if you use Pearson, you won't get an accurate answer. In that case, you have to use Spearman, as Spearman is used in non-normal distribution. Then, like I have stressed about earlier about Welch t-test, if we know that both cases have very different sample sizes, very different for population from each other, we have to use Welch t-test rather than student t-test. Then if we are comparing, just like how Dr. Alaa have been talking about, if we have multiple comparisons, if we have multiple factors that could affect an outcome, we have to do adjustment to them. just like Dr. Alaa have been talking about earlier, because there is a lot of confounding factors with red wine consumption and improved health. We always have to adjust for other potential confounding factors such as diet, exercise, and mental health. Then, if you're reporting correlation and saying that it's actually causation, again, that's an incorrect interpretation, just like we have mentioned earlier. A correlation does not always mean causation. In order to show two things happening together does not mean that one is the cause of the other. So once again, we have to do adjustments, and we have to see if there is another potential confounding factor that could change our result, that could explain the reason why they occur together. Then finally, instead of doing a single ANOVA test where we can compare 3 or more means, you do a multiple t-test. Here you can get more false positives, and you will get an incorrect interpretation. Rather, instead of doing multiple t-tests to compare 2 or more than 2 means, it's preferred to use one single ANOVA test, as it can compare 3 or more means. And that's it for my presentation. If you have any questions, I'll be happy to answer in the chat box.
Thank you so much, Dr. Mohammed, for great presentation. And I think this is very good overview of what tools you need to use and when to use it. But thank you so much. Yeah, it's very important to know that. Thank you. If no other questions or comments, we can go ahead with the next presentation. Do we know if Dr. Malaz are available?
Yes, can you hear me well, Dr. Nader?
Yeah, I think you are muted. Yeah, now we
Okay,
can
I'm
hear you.
sorry.
Thank you.
Okay, let me just share my screen. Is it clear?
Yes.
Firstly, hello everyone. I hope you all are doing well. I'm really happy to talk with you today about silent memory because as clinicians, it is a very interesting topic that we actually see in our daily practice. And thank you so much, Dr. Nader, for this opportunity. As clinicians, we are trained to look for a deficit, for what is missing and what is lost. So when a patient tells us they cannot remember something, our thinking moves very quickly. We assume the memory is gone, we assume erasure, and what's important to keep in mind is that this assumption strongly shapes how we diagnose, how we counsel, and how we talk to patients and families. Now imagine with me a patient after a traumatic injury. The patient is awake, alert, and interacting normally. Language is intact, attention is intact, and learning is clearly happening. However, when asked about a specific memory from before the injury, the patient says, I know it mattered to me, but I can't bring it back. So clinically, that moment stayed with me. Later, when I came across this sentence by Dr. Christian, imagine your memories are not gone forever. They are just silent. That was exactly when everything clicked because it described what I was saying clinically, but struggling to explain, and that brings us to the silent memory. So it's some memories may not be gone, but simply silent. That naturally leads us to a very important clinical question. Is memory loss always memory erasure? As clinicians, when we label something as memory loss, we often treat it as final, something definitive and irreversible. But actually, it's important to keep in mind that this way of thinking may be too simplistic. So before we go deeper into the discussion of silent memory, it's important to pause for a moment and carry a few key concepts with us, because these concepts will shape how we interpret everything that comes next clinically, not just theoretically. So let me briefly walk you through three important concepts. First is recall failure. Recall failure simply means the brain cannot retrieve the memory at that moment. And what's important to keep in mind is this inability to retrieve does not mean inability to store, which means the memory may still exist, but the brain cannot access it. Second, preserved learning. Clinically, we often see patients who cannot consciously recall an experience, yet their behavior clearly shows learning. They adapt, they respond, they change, and that tells us something very important. The brain has learned even if recall has failed. And finally, storage versus access. Memory storage refers to whether the memory exists in the brain. Memory access refers to whether the brain can retrieve it when needed. And that is, it's critical to understand that these two are not the same. So now that we have reframed how we think about memory loss, the next question becomes clear. Why does this actually matter in clinical practice? Because memory complaints are extremely common, we hear them every day across specialties, across age, and across diagnosis. And when a patient says, I'm forgetting, our instinct is to think of memory loss something permanent and progressive. But what's important to keep in mind is that not every memory complaint reflects true memory erasure. Clinically, recall failure does not mean the memory is gone. It means the brain cannot retrieve the memory at that moment. At that same time, learning can remain preserved. Patients adapt, they respond, they change, which tell us that the brain has learned even when recall is impaired. And this brings us to critical distinctions that directly affect our clinical decisions. Memory storage refers to whether the memory exists in the brain, and memory access refers to whether the brain can retrieve it when needs, as I said. And these two processes are not the same. When we confuse storage with access, we risk misinterpreting what the brain is actually doing. We may overestimate neurodegeneration, underestimate recovery potential, or miss opportunities for targeted rehabilitation. However, when we recognize silent memory, our thinking shifts. We start asking better, more precise questions. Is this a failure of storage or a failure of access? Is the memory destroyed or temporarily unreachable? And that shifts matter because it influences diagnosis, prognosis, counseling, and rehabilitation strategies. So clinically, silence memory reframes memory complaints not as the end of memory, but as potentially modifiable problem of access. Before we define silent memory, it's important to ask a more fundamental question. Why does the brain why does the brain rely on silence at all? For decades, neuroscience was dominated by neurocentric view. If something mattered, it had to be electrically active, firing action potential. But the Nature article we are drawing from clearly shows that this assumption is incomplete. The brain is not designed for continuous activity. Persistent neuronal firing is metabolically expensive and biologically inefficient. And instead, the brain has evolved mechanisms that allow information to be preserved, integrated, and regulated without requiring constant neural firing. And this is where the concept of silent memory emerges. As we know, memory storage means the information has been encoded within neural circuits, while memory recalls means the reactivation of these circuits into conscious awareness. And this leads us to the key principle we need to keep in mind throughout this discussion. The absence of recall does not equal the absence of memory. Significantly, silent memory refers to memory traces that are stored without persistent neural activity. And at the neuronal level, synaptic connections remain structurally intact. At the circuit level, ingrown cells still exist, but these networks are not actively firing at that moment. This does not mean erasure. It means the memory is in a latent silent state, not actively firing. And it's so important to know that not actively firing does not imply inactivity. It means information is not being expressed through fast electrical signals. And this is exactly what the Nature article highlights when it introduces the role of astrocytes. And astrocytes do not fire action potential like neurons. And instead, they use slow calcium-based signaling operating over seconds to minutes. They allow them to integrate synaptic activity, neurotransmitter spillover, and metabolic changes over long periods of time, almost like the brain's long exposure, almost like the brain's long exposure camera. So information can be maintained and modulated silently without continuous neural firing. And this brings us to the final point on this slide. Storage is not the same as recall. A memory can be biologically present, encoded in synapses, supported by astrocyte neuron interaction, yet temporarily inaccessible to conscious retrieval. And clinically, this explains something we see all the time. Patients may report memory loss, yet still show learning, emotional responses, or behavioral adaptation related to that experience. So silent memory is not a failure of the brain. It's an adaptive strategy, a way for the brain to preserve information efficiently and express it when needed. And in the brain, silence does not mean absence. It often means preservation. And silent memory reflects how the brain stores information beyond electrical activity. Now that we have defined what silent memory is, the next logical question becomes, how does the brain actually implement silence? Because silence in the brain is not passive, it is hierarchical, structured, and biologically regulated. Silent memory operates across multiple levels, organized in hierarchy rather than at a single point. And across all these levels, there is a one shared core mechanisms: absence of persistent firing. Let's start at the synaptic level. At synapses, memory can be stored without continuous neural firing through changes in synaptic strength and receptor composition. These synapses are structurally intact but functionally quiet. This is what we call silent synapses. So here, the memory is present, but it's not actively expressed. But memory is not stored at isolated synapses. It's organized into neuronal ensembles, groups of neurons that work together. These ensembles from what we call an engram. An engram is the physical trace of a memory in the brain. At the circuit level, these engram circuits can remain biologically intact, even when they are not firing. They are not erased. They are in a state of dormancy. And this distinction is critical. Dormancy does not mean disappearance. It means the memory trace exists, but is temporarily offline. And the Nature article clearly highlights that memory-related circuits can persist even when they appear electrically silent. Now we move to the functional level. At this where silent memory becomes clinically meaningful. At this level, behavior and learning can still shaped even when neurons are not actively firing. This is possible because memory expression does not rely on spikes. It depends on network level modulation. Here, the brain can maintain internal states, influence behavior, support learning without obvious neuronal activity, and this prepares us for the next crucial question. Silent memory is not stored in one place. It emerges across synapses, circuits, and functional network, organized in hierarchical manner. And silence here is not failure; it's efficient biological design. So. So we clarified how silent memory is implemented through hierarchical mechanisms across synapses, circuits, and functional networks. The next questions become, in what form does this silence actually appear? Using the same mechanistic framework, silent memory can be classified into distinct types, each representing a different expression of the same underlying principle, the absence of persisting firing. Firstly, the silent synapses. At the synaptic level, silence manifests as a silent synapses. These are synaptic connections that are structurally present, biologically intact, but functionally inactive under baseline conditions. Here, silence serves as an important role. It preserves synaptic connections in a latent state, maintaining a reserve for plasticity and future learning. So at this level, silence is not loss, it's potential. Second type is a silent engrams. At this circuit level, silence appears as a silent engrams, and engrams represent the physical memory trace encoded across neuronal ensembles. In silent engrams, encoding has occurred, storage is preserved, but retrieval is inferred. This means the problem is not memory formation, but access. So the memory exists, but network required for recall is temporarily offline. The third type is silent engrams. Silent engrams in Alzheimer's disease. Sorry. So silent engrams in Alzheimer's disease. Because not, I can't see the screen well. Is it clear, Dr. Nadir? I'm sorry.
Yeah, it's clear. Silent engrams in Alzheimer's disease memory trace may persist. Is this a slide?
Yeah, okay. So silent engrams in Alzheimer's disease. This distinction becomes especially relevant in Alzheimer's disease. Traditionally, memory loss in Alzheimer's has been interpreted as irreversible erasure. However, emerging evidence suggests that some memory traces may persist while retrieval pathways progressively fail. In this context, at least part of memory loss may reflect silencing of memory circuits rather than complete destruction. So this reframes Alzheimer's disease from a purely degenerative process to a one involving functional network disconnection. And we have activity silent working memory. So finally, silence can occur even in working memory. Here, information is maintained without continuous neuronal firing through transient synaptic states and short-lived network configuration. This allows the brain to remain metabolically efficient while preserving rapid responsiveness to new stimuli. So even short-term memory does not always require sustained activity. So that means across synapses, circuits, and cognition, silent memory represent preserved information with suppressed expression, not lost. So now that we have built a solid understanding of silent memory, this naturally leads us to a very important realization. Silence in the brain does not mean the brain is inactive. In fact, silence itself represents an active brain state. Firstly, silence does not mean inactivity. Firstly, it's important to challenge a long-standing assumption in neuroscience. For decades, we equated brain function with neural firing. If neurons were not producing action potential, we assumed the system was inactive. However, recent evidence, including what we have seen in the Nature article, clearly shows that this assumption is incomplete. Memory-related information can persist, networks can remain organized, and behavior can still be influenced, even when neurons are electrically quiet. So silence does not mean nothing is happening. It means the brain is operating in a different mode. Secondly, silence in the brain is not accidental. So that means it's an actively regulated state. It's actively regulated. The brain suppressed resistant firing to maintain stability within its network. Why? Because continuous firing is metabolically expensive, noisy, and destabilizing over time. By shifting into the silent state, the brain conserves energy, reduces interference, and preserves internal organization. So silence here reflects control, not weakness. Thirdly, silence reduces neural noise. Silence plays a critical role in reducing neural noise. Not all neural activity is beneficial. When firing becomes excessive or continuous, signals complete, overlap, and interfere. Silent states suppress background activity, allowing meaningful signals and memory traces to remain protected. In this sense, silence acts as a filter. It reduces noise while preserving important information. And silence is essential for memory consolidation. Long-term memory does not require neurons to fire continuously, and instead consolidation depends on synaptic restricting circuit level reorganization, slow biological processes. All of these processes occur most effectively when neural activity is regulated and reduced. Silence creates the optimal conditions for memories to be stabilized and integrated into long-term networks. So, silence in the brain is not failure. It's an active, regulated brain state that stabilizes circuits, reduces noise, and allows memory to persist. So if silence is an active and regulated brain state, the next question becomes even more interesting. What does this silent state actually enable inside the brain? And one of the most great answers is silence creates the conditions for neurogenesis. Firstly, hippocampal neurogenesis. Silence plays a critical role in hippocampal neurogenesis. As we know, the hippocampus is the one of the few regions in the adult brain where new neurons can still be generated, but this process does not occur during excessive neural firing. And instead, neurogenesis is promoted in a state of reduced neural noise, controlled activity, and a stable network environment. Silent states provide exactly these conditions. By limiting persistent firing, the brain creates a biological permissive environment for new neurons to survive, mature, and integrate into existing circuits. So silence here is not just protective, it's developmental. Secondly, silence enhances brain resilience. Um, Silence contributes directly to brain resilience, and we know resilience is not only about resisting damage, but about the brain's ability to adapt, reorganize, and recover. So silent states allow the brain to reorganize synaptic connections, recalibrate circuits, and integrate new neurons without destabilizing existing networks. So this is particularly important under condition of stress, aging, or new degenerative diseases. In this sense, silence acts as a buffer, protecting the brain while enabling adaptive change. And thirdly, silence supports memory. Silence plays a key role in memory support. Newly generated neurons in hippocampus are especially important for memory flexibility, pattern separation, and updating existing memories. But these neurons need a stable background to function. Excessive firing interferes with this process, and silent brain states allow memory circuits to integrate new information without overwriting or destabilizing stored memories. So silence does not weaken memory, it supports memory by preserving balance. So that means silence is not just about suppressing activity. It creates the biological space for growth, resilience, and memory renewal. So if silence supports neurogenesis, resilience, and memory renewal, then silence is not just a biological curiosity. It becomes a clinically relevant, and this is the moment where silent memory moves from neuroscience into clinic. Firstly, reframing memory complaints. Silent memory fundamentally reframes how we understand memory complaints. As clinician, when a patient says, I can't remember, our default interpretation is often memory loss. But a silent memory challenges that assumptions because absence of recall does not necessarily mean absence of memory. It may reflect a literal failure, a temporarily silent engrams, or reduced access rather than erased storage. This reframing is critical. It shifts our clinical mindset from the memory is gone to the memory may be present but silent. Secondly, impact on prognosis. This directly impacts prognosis. If memory traces are silent rather than destroyed, then the trajectory is not always linear or irreversible. This opens the door to potential reactivation functional improves and more nuanced expectations over time. In other words, prognosis is no longer binary, lost versus preserved. Instead, it becomes dynamic depending on access, network state, and modulation. And that is profound shift in how we think about recovery. Thirdly, guiding patient counseling. Silent memory rehabs how we counsel patients and families. Instead of framing the narrative as loss and inevitability, we can introduce a more accurate and more human explanation. We can say the brain is still holding information, memory may be offline, not erased, and function may fluctuate rather than disappear. This does not create a false hope. It creates a realistic biological grounded hope. And that matters for patient engagement, adherence, and psychological well-being. So that means silent memory changes what memory complaints mean, what prognosis looks like, and how we talk to our patients. It reminds us that silence in the brain is not failure, it's a different state of function. So this brings us to one step closer to real life. In modern clinical practice, most of our patients, and honestly, most of us are never truly in silence. There is always a background stimulation, music, podcasts, headphones, notifications. And while this feels harmless, neuroscience tells us something important. Constant auditory input keeps the brain externally driven. That means less space for internal replay, for consolidation, and for silent memory mechanism to operate. Fancy headphones are not always neutral, and headphones are not always protective. Continuous background sound keeps memory circuits in an online state even when no learning is happening. This does not mean music is bad. It means the brain also needs periods of intentional silence to recognize and reset and rest. Sorry. And secondly, silence improve focus for recall. Improve focus and recall. Silence improves working memory and attention, and periods of quiet reduce neural noise, lower cognitive load, and improve accuracy in recall. So silence is not inactivity, it's a signal optimization. And thirdly, silence supports brain resilience. And as we know, silence supports neurogenesis. Even brief daily periods of silence have been shown to trigger the growth of new neurons in the hippocampus and core structure for memory. So silence becomes a form of biological resilience, not just psychological rest. So finally, what does this mean clinically? It means we can give our patients simple, evidence-informative advice, short walks without headphones, screen-free mornings, quiet breaks between cognitively demanding tasks, around 1 to 2 hours of total quiet time per day, broken into short intervals, can support memory circuits and cognitive health. And if silent memory exists, then silence itself becomes therapeutic. And when we recognize silence as a functional brain state, we stop treating it as empty time and start treating it as a part of cognitive care. Finally, as we conclude the key message, I want us to leave with this. The brain is far more resilient, efficient, and strategic than we often give it credit for. Memory does not disappear. The moment it stops firing, it can exist silently, stored, protected, and biologically intact. And what we often label as memory loss may, in many cases, be a problem of access rather than erasure. Silence, therefore, is not a failure state of the brain. It's an active, functional, and protective state. A state where the brain reduces noise, preserves information, supports plasticity, and prepares for future recall. This perspective challenges the way we think about forgetting, cognitive decline, and even neurodegenerative diseases. It reminds us the absence of recall does not automatically mean the absence of memory. As clinicians, this matters. It shapes how we interpret symptoms, how we counsel patients, and how we think about prognosis and recovery. Because if memory can exist without constant activity, then silence is not the end of the story. It may be part of brain's strategy to survive. And perhaps the most important takeaway is this. Sometimes the brain is not forgetting, it's simply being quiet. Thank you so much. And I would be happy to take any questions.
Thank you so much, Dr. Malaz, for this excellent presentation. And I think it's an important topic. Nature has many articles, and one of them is this one, which is great. When you have a minute, maybe you can read it. So I'm going to upload that to the app as well. But thank you so much. Any questions or any comments? Yeah. If no questions, we can go to the last section, updates. And I'd like to share with you good news. We have Dr. Nuha Yasin. She matched, she called this morning and she matched to an internal medicine, I think, internal medicine residency program in New York City. So congratulations. And this was a pre-match. So any news from you guys or any comments, questions, ideas, progress, updates? Thank you. How is your projects, if you are working on any of the projects, research project, any updates? Okay. If none, I'd like to thank you so much, Dr. Mohammed, and all your teams, your team members, and also all the presenters from today's presentation. Thank you all. Thanks those who attended this morning and this meeting, and those who will watch the recording in the future. I'd like to thank you in advance. So we'll see you next week. If you have questions, please let me know. Send me an email, contact me via WhatsApp or call and text. I'll be happy to assist as much as we can. We'll see you next week, inshallah. Assalamu alaikum. Thank you all again. Assalamu alaikum.